Hi, good afternoon, everyone. Welcome to Ethics for Lunch for January, the start of a new year. My name is Mark Hughes. I co-chair the Hospital Ethics Committee along with Cinda Rushton. And as many of you are aware, Ethics for Lunch is our monthly opportunity to discuss ethical issues as they pertain to patient care at the hospital. It is a session sponsored both by the Ethics Committee and the Berman Institute of Bioethics. And we are fortunate today to have a panel that will be talking to us about immigration status. I'm going to turn the session over to Zach Berger, who is a faculty member in General Internal Medicine and the Berman Institute of Bioethics, to talk about the topic.
Great, thank you, Mark. I want to briefly introduce the general topic of immigration status and healthcare. And the reason I want to generally introduce it first is because, it's my job as a bioethicist to talk about things being complicated. And that's true, but we at the same time don't want to miss the forest for the trees. And so I'd like to talk about the general contours of the topic in a very brief way before we get down to the cases that we've prepared. And I want to thank Simone Thompson for bringing up this topic. I think three general points I want to make very briefly to help organize our thoughts as we talk about particular cases and the experience of particular patients. The first is that although, again, the details can be complex, the moral principles, I think, are relatively clear. That is, in general, that people should have equal access to healthcare, and immigrants do not because of accidents of birth or the accidents of pieces of paper or the accidents of where borders are drawn. And that's something to keep in mind. The second principle also to keep in mind is that we're all part of imperfect institutions that are complicit in various ways with injustices directed at immigrants. And it's important for us to realize that these issues are not dependent on the behavior or the good behavior of individuals. They also depend on policies that we can try to change. And my third point is sort of an example of the second point. It's interesting that at our institution, and I think at other healthcare institutions, people, clinicians and others are still in the healthcare record mentioning people's immigration status. And that's what's generally speaking not needed to deliver care to a person and can be stigmatizing. But even something that is a relatively uncontroversial practice that is uncontroversially seen as a practice that should be changed is a hard practice to change in some settings. So that's just an example of how simple ethical principles can become complicated because institutions are hard to change. And those general principles being said, and thank you very much for indulging me in those in general introductions, I want to thank again the other members of the panel and Simone Thompson, and she's going to read a couple of sample cases that we've prepared to illuminate the complex and the details that come into play when we're talking about these general topics.
Okay, so we'll do the case presentations and then introduce our panelists, Zach?
Great.
Okay. So our cases today, we decided to review two, in part because this is something that varies depending on the age of the patient, in addition to other issues. So we wanted to include both an adult and a pediatric patient. The first is one that Dr. Berger himself brought forward. Senora PBG is a 37-year-old female from El Salvador. She is a former painter by trade and immigrated from El Salvador to the US in 2015. She has often suffered from housing and food insecurity. As a non-citizen, she is not eligible for medical assistance, but she has been approved for the Hopkins Access Program, or TAP. She sees specialists through TAP and obtains primary care at the Esperanza Center Health Clinic, where Dr. Berger is a provider. Ms. PBG has a family history of diabetes and a personal history of diabetes, heart failure, and active treated tuberculosis. She's had dozens of hospitalizations since 2018, most often for volume overload. She started dialysis in 2020, and at a recent clinic appointment, she inquired whether she could be a candidate for kidney transplant. Our second patient, who was outlined again by one of our panelists, Ms. Jessica Contreras, is a 16-year-old woman and Honduran citizen. Her first name we've chosen, Encanto, presented to the emergency department with contractions and was admitted to labor and delivery. She gave birth to a healthy 8-pound baby girl and reports that she did not receive prenatal care as she was unable to obtain the identification, residency, or income information needed to attend a sliding scale fee clinic. It's not indicated in the summary, but she also, as a minor, had been unable to obtain a passport prior to leaving Honduras. Oh, that is indicated here, I'm sorry. She is not eligible for medical assistance as she has no documentation status in the US. Encanto entered the country about 2 years ago with a group of non-relatives, was apprehended at the Texas border, then held in a contracted detention facility in Tennessee for 11 months. Though she does not offer details, she says that there were a number of traumatic experiences during her travel from Honduras and in the detention facility. She was released to the care of family members in Virginia, but reports she ran away as she was treated like a servant, sometimes beaten, and not allowed to attend school. For the last few months, she has been working in Baltimore and renting a room in a boarding house. Her baby's father is supportive, but also has limited financial means, and she has few baby supplies. Encanto is afraid of being deported and says she does not want to ask for any help. She states concern that her baby may be removed from her care, as friends have told her the government can take your child or take her child if she gets any kind of help. She's also afraid of being returned to detention. The medical team states concern that Encanto will be unable to provide appropriate care to her baby, given her immigration status and its effect on her ability to be insured and obtain resources. Zach, do you want to do intro? Except you're on mute.
I'm very embarrassed. I don't have the information to introduce people.
Well, I can do that.
My apologies for screwing up that.
Okay, well, we'll maybe let you off the hook this time.
Thank you. I'm sorry.
So my name is Simone Thompson. I'm a social worker in the Children's Center, have been part of the ethics team for a number of years, and am the child protection team coordinator for Johns Hopkins. Our two panelists that are also Hopkins staff, to whom I'm inordinately grateful for agreeing to participate today. Jessica Contreras is a licensed social worker who is a bilingual provider and works at Bayview Medical Center in outpatient predominantly, is that correct? And then Wardy Donnelly is the director of the Hopkins Access Partnership, as mentioned for one of our patients earlier, and came to join Hopkins from the Esperanza Center previously. So thank you again tremendously for participating today, and Jessica for helping in doing a case description for discussion. Do participants have, or I'll ask both of you to comment on the cases, or Dr. Berger to comment on cases as they were presented, and then we'll have opportunity for participants outside the panel to ask questions.
Sure. So maybe I'll comment on the first case. I had invited the patient herself to be present as an audience member in today's session. So I do not unfortunately see her yet, but if she manages to come, we can hear her thoughts, which I would interpret. So I think just to summarize is that this patient has had a number of challenges, and a lot of them are due to an intersection of topics, which really often come about, as our other panelists can, I'm sure, comment as well, in the setting of healthcare of immigrants. So it's not just immigration status or documentation status, it's the fact that that status often coexists with economic strain, housing insecurity, food insecurity, inability to afford medications, and difficulty accessing care. And so all those together are is a very difficult mix to combat when delivering care. So that's one thing I want to say. The second is that often people, and our other panelists can probably speak to this as well, I find, although I'm not a social worker and I don't always have detailed and in-depth knowledge of what resources are available, I know somewhat of what's out there. And I sometimes find that our patients just don't know what's out there because it's really confusing to keep on top of what the laws are, what their eligibilities are, and as in the second case, whether there might be deleterious consequences for taking advantage of resources. So sometimes the fact that someone is not taking advantage of what resources are available to them is not because they're, lazy or bad or uninterested. It's because it's difficult to surmount these barriers and difficult to have access to these resources if you don't know that they're there. So in the end of the case, of the first case that we read regarding this patient, where she asked whether it might be possible to get a transplanted organ, I think it was literally a question based on just not knowing, right? Like she sort of would assume or heard that transplant organs are available, and so why wouldn't they be available to her? So that's, I think, really the foundation of her question. Unfortunately, I don't think she's here to talk about what she understands about that question, but I think that's really, again, forest for the trees kind of issue, that it doesn't make sense a priori from a clinical perspective why one person would get a transplant organ, why another person would, right? And in fact, her comorbidities for other diseases, after a very long time and many hospitalizations and the efforts of her and people supporting her and many clinicians, many of her conditions are actually reasonably well controlled at this point. And she's a relatively young person. So from a clinical perspective, she would be a good candidate for transplant. So that's my thoughts about this particular patient's experiences, and obviously happy to discuss questions, but maybe our other panelists, I don't know what order we want to go in. Simone, they can maybe comment with their expertise on eligibility and reasons for lack of eligibility with regard to this patient's story. Maybe we should go to the second case first, whatever your thoughts are.
I don't have strong feelings about it. I think one of the things that I found interesting just in putting the cases together is that with a lot of feedback from Jessica, that I'm used to describing patients and their context and their needs, based as a social worker on talking about agency engagement and resources and the tremendous number of acronyms that are often involved. So Jess corrected me in a very supportive way, explaining that this 16-year-old, and in fact, many patients don't understand or even know that there is a difference between, for instance, immigration and custom enforcement and law enforcement and the Department of Social Services, and that and trying to put forward her story using those agency names, that it would obscure what she actually understood about her own situation. So Jess, I guess if you could speak to your experience working with the immigrant population and their understanding of, as Zach said, service availability, but also the limitations placed on not even understanding systems.
Sure. Thank you so much for inviting me. And Simone, special thanks to you because we spent a lot of times emailing back and forth and discussing this very real case that is based on someone that I have been working on. So first of all, my name is Jessica Contreras again. I am an immigrant originally from Guatemala, and I was born and raised in a time in Guatemala, especially in the 80s, when there was basically a civil war going on. And many Guatemalans left, particularly Central America, for that reason. And you will see many Guatemalans that are settled here, in part because of that. What has come to my mind, I think, recently has been that, particularly not just for Guatemala, but many Central Americans, many of the new arrivals coming into, particularly from Central America, are kind of like the grandchildren now of the wars, right? And so when you think about Honduras and when you think about Guatemala, especially El Salvador, many of these families have been impacted now, not just by the wars that happened then, but also high levels of poverty, lots of storm and natural disasters that have occurred. And what has been really surprising to me is the high number of patients that have very low literacy. So when I thought about Encanto, I thought about so many of the families that I have recently been working with. And I'll see my colleagues coming in with interpreters. And, we've gotten really good about coming in with interpreters and talking to patients. But when asking them questions, there are many things that are not going to make any sense, right? And so, what is the Department of Social Services? Why didn't you get prenatal care? But why didn't you get a passport, right? Shouldn't it be easy for you to get a passport with the embassy? And when you think about something as simple as an ID, even getting an appointment with some of the consulates from El Salvador, many other countries, it's simply not existent since COVID. And so it starts there. So if you have no access to an ID, you are going to have a very limited access to even access prenatal care. Thankfully, I think in Baltimore City, if you want primary care or prenatal care, there are local resources that you can access, but a lot of times it often requires also for you to be able to have an ID. For this young woman, she had no identification and therefore she had no resources. And so when I went talking to her, the first things that I did is really build rapport with patients. And I wanted just to know her story, right? I didn't mention what the concerns from ours was. I really wanted just to hear her. And, I think during this time of COVID, it's very difficult to listen to those stories because we kind of want to rush and we're being told we need to discharge patients. But for this young woman in particular, because of her age, because she was alone, because she had reported abuse, Department of Social Services had to become involved. And I spent lots of time just talking to her, reassuring her, explaining the differences. And so one of the things, if you were to ask me key points to learn out of this is interpreters are important, but interpreters are also our biggest allies. And so I think it's important as you work with interpreters, for example, that you ask the interpreter, is what I'm saying making sense in the language that you are interpreting? Because lots of things do not translate well. I think it is important to assess the needs of our patients, is what are their understanding of systems, and what has been their experience. Lots of our patients, for example, I don't know, some people may or may not know this, but for women who are pregnant in Baltimore City, for example, they can get an emergency medical assistance number prior to them delivering so that their deliveries are actually covered, but many patients do not necessarily understand that. So what is their own understanding of what's going on with that? And really supporting and listening to the stories makes a huge difference.
Wardy, what's your perspective, particularly as an administrative level coordinator for such an important service as TAP? And actually, if you could describe what TAP even does, I think that would be helpful for many people.
Sure. So the TAP program is a charity program from Hopkins. It is for patients that do not qualify for the Affordable Care Act, and they need services at Hopkins. They can get these services free of charge. They can get specialty, they can get surgery. TAP doesn't cover everything, doesn't cover medication, and it does not cover any type of medical equipment like braces or any DME. I would think substantially most of the most important things that patients need. As far as the needs of the patients, I think one of Jessica was right. I'm astonished how the language barrier has to be one of the biggest blocks that our patients run into. The misunderstanding of what's going on, not having an interpreter present at the moment, or somebody who is doing the interpretation is not qualified enough to do the interpretation. I had a patient 2 weeks ago that she was in the ED. Now she had been transferred to an emergency facility at Hopkins. She had metastatic cancer. We wanted to tap her immediately so that she could get covered and get the treatment she needed. I remember calling her partner and asking him a little bit about, I didn't want to call her at the hospital in her condition. So I thought, let me just qualify him at least over the phone. I talked to her partner. He says, I wish they would do surgery on her. And I'm like, why would you want that? And he goes, I'm afraid that her cancer might spread if they don't do surgery. And it just hit me at that moment that her partner had no idea how sick. And of course, during COVID, I'm not sure if he was allowed to visit her, how sick his partner was, his significant other. And sure enough, I had that conversation with him on Monday where he was very worried that this cancer could spread. 4 days later, she passed away. And it just hit me how something as simple as the family having the right information, how difficult that was. So I think language is one of the biggest barriers right now for the medical treatment of these patients, the right treatment, for them to know what their rights are and what's going on with their own treatment and their family knowing what's going on with their loved ones.
If I could take a moment, thank you, Wardy, as always, for your expertise and detailed knowledge that you bring to this discussion. We have the benefit of a patient here that I just mentioned in the first case, who I work with, Patricia Baños, and I'm going to ask her in a moment to share her experiences, and I'm going to interpret from her Spanish. And so I'm going to allow her to talk. Hola, señora Baños.
Aló.
Aló. Muchas gracias por participar. Yo voy a hacerle unas preguntas y yo voy a interpretar después, ¿ok?
Está bien.
First I'm going to ask Ms. Baños about her experiences with her kidneys and her understanding of transplant. Y si puede describirnos sus experiencias sobre sus riñones y diálisis y cómo entiende usted si usted podría recibir un órgano trasplantado y cómo cómo usted ha aprendido sobre ese tema?
Aló, aló,
Aló. No estamos escuchando.
aló, ¿me escucha?
Sí, ahorita escucho, sí.
Que me puede volver a repetir la pregunta que no
Sí.
se le
Yeah,
escuchó.
I'm gonna repeat the question. ¿Sí puede describirnos sus experiencias con sus riñones y qué entiende usted sobre recibir un órgano y cómo ha aprendido usted sobre ese tema?
Pues yo en el 2001, en el 2001, me diagnosticaron con insuficiencia renal. Pues ahorita, como por el problema de que yo no tengo documentos, me es bien difícil yo poder hacer mi trasplante. Entonces ahorita solamente estoy esperando y nada, espero nada más y yo sigo con mi diálisis, con mis dietas, con todas las recomendaciones de mi doctor, de mi nefrólogo, y eso es todo.
Gracias, permítame. So, Senora Baños told us that she was diagnosed with chronic renal disease in 2000 or 2001. And she understands, she says that she is not eligible for a transplanted organ because of her lack of a documentation. Since then, she's been pursuing all the medical recommendations, including diet and medications. And she said, there's really nothing to do but to wait, because she understands that she's not going to receive an organ, but she's just following these recommendations. So I'm going to ask her now what her thoughts are about not being able to receive an organ given her documentation status. ¿Cuáles son sus pensamientos de usted, señora, sobre no poder recibir un órgano? Depende de su estatus de documentación.
Pues luchar y tratar de salir adelante con esta enfermedad, y pues no me voy a cansar de buscar algún medio posible para yo poder trasplantarme un riñón.
Permítame. So she says her response is to fight and to keep moving forward, and not to get tired, not to rest until she finds some sort of way to get a transplanted organ. So, and before we go to the other discussions of the panel, one more question. Yo voy a hacerle una pregunta más, señora, y después vamos a tener un poco de discusión en el panel. ¿Cómo usted conoce a otras personas que han recibido órganos trasplantados en otros estados o otras situaciones?
Pues no, la verdad no conozco a nadie que haya recibido órganos en otros estados. Simplemente he escuchado que en California es más fácil para obtener un trasplante de riñón, pero nada más. No he investigado más acerca del tema.
Gracias. So Señora Baños, that she does not have any family or friends that have received a transplanted organ, but has heard that in California, it is easier to receive one, but has not researched it in detail. So perhaps we could, puede ser que vamos a hacer unas preguntitas más, pero ahorita vamos a hacer una discusión en el panel. So maybe we could, if there are questions around in the panel about these two cases, and then we could ask Senora Baños more questions later.
Certainly. So one of the first questions, and this is from Mark Hughes, our ethics chair, is whether patients without documentation or who aren't eligible for medical assistance are able to receive hemodialysis or peritoneal dialysis, and if so, who pays for it?
I guess I can start answering the clinical question. That the payment, I think my colleagues on the panel can better speak to that. But I will say that there are a couple points of entry for undocumented people into dialysis, and often it's through an emergent route. That is, they have some sort of acute symptoms or imbalance in their electrolytes or shortness of breath or other of the classical situations that would make someone eligible to need emergency dialysis, and they get that in the emergency room or they get that in an inpatient hospitalization, and that is definitely covered, I believe, by emergency Medicaid. Then the question is, what happens for these people in order to be able to get outpatient dialysis on an ongoing basis? And that does happen. It's a difficult series of steps, but at least for some people it happens. And I'm going to pass the buck to the fellow panelists who can speak more to that in detail.
Jessica, would you like to touch on it, or I can?
I think Wardy primarily has a little bit more since she works more with.
That's also true.
The only thing I probably would add to Dr. Berger's comment was that, the emergency assistance can help, but that can take months to apply. And so as long as the patients also know that an application can be submitted, and then in addition to that, they can also apply for hospital assistance for those ER visits. So patients can come into our financial assistance office. We have, at least in Bayview now, Spanish-speaking staff who are able to assist with the application process for those ER visits that may not necessarily be covered by emergency medical assistance.
So it's correct. There is Medicaid for patients who need dialysis. It's called XO2 and XO3. What happens is once they go into the emergency room, the process needs to be started immediately. They have 3 months to get that process started and to be able to get approved. Once approved, they can have the dialysis under a certain insurance that will cover that. The process is very difficult, like anything else that has to do with the state. It's very involved. And what happens is, in the meantime, while all this is happening, they get what it's called an LOA. So it's an agreement that Hopkins does with a dialysis center for this patient to get treated through dialysis, which I think is Patricia's situation too now, Dr. Zach. And so they get the dialysis. My understanding is that in most cases, Hopkins pays it. If they've gone into Hopkins emergency room, they continue their dialysis. And then from there, they try to get them into the insurance. I literally have never met anyone that has been tapped then to dialysis that have gotten the XO2 or XO3 yet, because our patients get very confused with the paperwork they need to bring in, and they don't bring it in time. These are all time sensitive. But if it's done perfectly, which is very difficult, they can get that insurance. I have not seen it happen yet. So it is hard.
I can speak, and I think, Wardy, you're speaking more to the adult population, correct? So for pediatrics, some of the service availability or insurance availability is different. If they are born outside of the US, they are still not eligible for medical assistance. And there's often confusion by providers regarding that because it's assumed, oh, well, children should be able to get insurance. And it's not the case. But we are able to assist families in applying for what's called Children's Medical Services, which is, again, a state-based program specifically for children with complicated medical conditions. As Wardy said, for the insurance coverage she mentioned, the application process is painful. It requires a lot of documentation, proof of things that families that are living sort of under the radar often do not have. So for instance, proof of income. If you are working under the table, which is what's required if you don't have a social security number, which you cannot get if you are not a citizen or have legal standing in the United States, then you don't have pay stubs. And so it takes having someone who is willing in front of a notary to say that they in fact pay you an income every number of weeks, or someone else to attest that they are covering all of your expenses. And that's just one of the pieces of documentation. There's also residency requirements. And we've realized within our department for pediatric social work, the importance of this for families and do as much hand-holding as we can. But again, as Wardy mentioned, there are time requirements or rather requirements that things be submitted within a certain time frame. And even that is not necessarily reasonable, given that we also have to show that a family has applied for medical assistance and been refused. We already know that they can't be approved because of their immigration status, but denial is still required. It's one of those sort of Escher kind of situations as far as government bureaucracy goes. And the application and denial for medical assistance in and of itself, again, Jessica mentioned this, can take several months, but you are required to submit the denial with the CMS application that has to be completed within something like 60 days. So there's a lot of moving parts, which I do not believe are designed to be friendly to the applicant. Are there other questions or thoughts from our participants or follow-up thoughts from our panelists?
Simone, I thought I could, if you don't mind, I was going to ask Señora Baños about her experience with dialysis, since Wardy had mentioned that. Hola, señora Baños, si puede decirnos un poco sobre su experiencia con diálisis, cómo usted consiguió diálisis y si usted recibe una factura o cómo es su situación. ¿Le parece es una situación estable? ¿Cómo es para usted?
Cuando yo caí en diálisis, yo siempre he sido, yo siempre he sido paciente de Joe Hawking. En Joe Hawking me pusieron mi fístula y ellos me consiguieron un lugar donde yo podía estar yendo a recibir diálisis. Yo comencé a ir ahí a ese lugar que ellos me consiguieron para el diálisis, pues al principio fue algo nuevo que yo iba a vivir, con miedos, con interrogantes, aún todavía tengo interrogantes. Ellos me enviaron a ese lugar, yo estuve yendo a ese lugar, por medio de Esperanza Center, yo conseguí un seguro de Kaiser. Entonces yo les dije que yo tenía una tarjeta de seguro de Kaiser, pero yo no sabía si eso funcionaba o qué.
Permítame, yo quiero traducir, permítame. So Ms. Senor Baños was telling us that when she first started dialysis, she was under Hopkins care, and she received her fistula through Hopkins, and thereafter was a dialysis center was found her through Hopkins, and then she received insurance through Kaiser, and got an insurance card for Kaiser. Puede seguir.
Y ellos me mandaron para el centro Davita Diálisis, y desde entonces yo he estado yendo, cambié de centro de diálisis, ahora estoy en Davita, y pues ellos han conseguido, yo estuve recibiendo facturas, pero la trabajadora social me decía que se las llevara, y pues ellos me han solventado eso, ya que yo carezco pues de económicamente, pues no estoy muy bien. Entonces ellos me han estado ayudando con el pago de las facturas y todo. Solamente he tenido que comprar mi medicina, y ya hace poco ellos consiguieron que, porque por falta de pagos a mí me quitaron el seguro de Kaiser. Entonces ellos consiguieron, la trabajadora social consiguió que me volvieran a dar el seguro de Kaiser, y ellos me están ayudando también con los pagos del seguro mensual.
Permítame. So Ms. Baños was saying that she was switched to the to a Davita dialysis center. She has been reporting, she has been getting bills for some time, and the social worker, she means, I think the social worker at Esperanza Center has taken care of those. Because she doesn't have anything to pay with, she was dropped from Kaiser insurance because of inability to pay, but she was recently restored. And so the social worker has been helping with those. She does have money, she says, to get her medications. Gracias, señora. Me parece que ahorita vamos a pasar a más preguntas.
Okay.
One thing I will say, actually, to sort of supplement Senora Baños' remarks, is that unfortunately, despite Hopkins' legal requirements to provide low cost or free care to a proportion of the population, which is in return for the tax breaks it gets, many of my patients at Esperanza do get bills, which are really psychologically harmful and disturbing. So I want to supplement. It's obviously Senora Baños has her own story, but it's a story that's repeated in a number of cases.
Well, and I guess I can.
Oh, sorry.
No, go ahead, Jess.
No, I was just going to mention that in thinking about access to primary care, oftentimes I hear colleagues say immediately call Esperanza and send everyone to Esperanza. And I mean, Wardy used to work there, so she can speak about that, but they're a very small program. And so I'm careful a lot of times as to who I send to them. So primarily new immigrants who, for example, have no documentation, they're great candidates, I think, for Esperanza, because they don't require a whole lot of documentation. But healthcare for the homeless is also a great resource to partner with and to send patients to. I have found them, they're great. They help with medication, they help with primary care, they have dentists. So they're able to do a lot of wraparound services. So I find them to be a great partner. There are patients also, for example, that may have some documentation, they may be paying taxes and they have to figure out a little bit more of that system. So Chase, Braxton, Baltimore Medical System, Total Healthcare, they're all also great partners to send patients to, depending on the individual needs. It is helpful as you assess patients to understand a little bit what their economic situation is, because although they may get sliding fee at some of the clinics, there are often lab fees associated with that, and patients don't always understand that even though they may pay, I don't know, $5 to $10 for a visit, there may be an additional co-payment for a lab or x-ray or anything else that gets done. And so depending on each individual situation, again, I find healthcare for the homeless to be a great partner for those patients that are really struggling understanding how to navigate systems.
I think that's a great point. And I would add that in my experience at Esperanza and also at Hopkins in a more limited way, as I think our panelists all know, so many people, especially during COVID, are afflicted by significant housing insecurity. So healthcare for the homeless will see anybody who is not just homeless, but also with unsecure or unstable housing. And that really describes a lot of people that I see personally.
Well, and that has the additional impact, sorry, Wardy, of
Okay.
the ability to receive your information about, like, for instance, appointments or information from the Maryland Health Connections if there's applications pending for medical assistance, or, you know, if you're moving multiple times within any given quarter, then the probability that you're going to miss the mailings that you get is quite high. The other thing that I've noticed when parents bring documents in to help with resources for pediatric patients, our ability to communicate with them in their language of origin is often quite poor. So it's not only using interpreter when a patient is in front of us, but we often send form letters and the greeting may be in Spanish, but the letter itself is in English. And even if the recipient is able to read in Spanish, their ability to read in English is not there, or they may actually be illiterate across the board. As Jess mentioned, many of our patients are not able to read in any language. So I think the ability to understand systems, and as I mentioned, I helped a family to complete a children's medical services application. And when they were finally approved, I felt like I had scaled Mount Everest. And I'm somebody who has worked within healthcare as a social worker for nearly 20 years, and it was so difficult. So I think that that's an important thing to keep in mind as well. Wardy, you were going to.
Yes, I just want everyone to keep in mind a few things. Healthcare for the homeless is a very good option. One thing, we think of healthcare for the homeless, someone who's homeless, but a lot of our population that we deal with rent a little room in an apartment that's not even under their name. That can very well be considered homeless, because anytime the tenant says, you know what, this room isn't available anymore for you, they have no place to stay, or some of them just stay in people's couches, and that's their bed in that apartment or that house. So a lot of our patients will qualify even if they're not on the streets. Another thing I wanted to mention is that Healthcare for the Homeless does have TAP. We have a TAP coordinator there, so if they need specialty care through Hopkins, they can access it through Healthcare for the Homeless. So those are really good options. The only thing is, if you have a patient that is critical, that needs more care than maybe just diabetic follow-up or high blood pressure, but the patient might have, you know, some sort of a cancer or something, or renal failure, a better option might be Esperanza for one reason. They have Epic. So the fact that as part of Epic, they know what's going on with the patient at the hospital at Hopkins, and Hopkins knows what's being done with the patient in primary care, which Healthcare for the Homeless does not have Epic as their software. And their TAP coordinator is bilingual, which unfortunately I find that it's very important when the TAP coordinator is bilingual. And in Healthcare for the Homeless, the TAP coordinator unfortunately is not bilingual, even though they do a great job in working through that.
In the absence of questions from participants, Jess, I guess I would like your perspective on, because the patient that you put forward is a juvenile, and the change in delivery, maybe not change in delivery model, but how it changes the approach if the patient is still a minor and in the country alone versus in the country with family, and how that may impact availability of resources.
Yeah, so as I mentioned earlier, this was a very real case for me. This is actually somebody that I work with. And unfortunately, we had to call the Department of Social Services, one, because she reported that she had been a victim of abuse here by relatives. And two, because she was going to need supports that on her own, she was not going to be able to. As you may be aware, Department of Social Services is not always the most nurturing kind of program. And so a lot of the work that we did as a team here was to educate her and to kind of know what to expect. Department of Social Services currently, at least in the city, because of COVID, they were not taking a lot of cases. And so when we first contacted them, they didn't feel like this was a case that they wanted to take. So we did some advocacy work around it because we really felt that this was a child at risk for abuse for many reasons, because she was alone, because she didn't have any kind of resource or any kind of support systems. The Department of Social Services finally did respond, and this young woman is now in foster care. And what's interesting about this case is that even though her child is not in care, mom is, and she's getting, she has insurance, she's getting therapy, and she has some other additional services. But this has been a big road for her, right? Because again, DSS oftentimes is not very nurturing, so they didn't understand her. There have been lots of communication issues. And what my role, because she brings her child here, has been to kind of help her understand, who is this person? If you think about, well, not everyone here probably understands the child welfare system, but she has an attorney. Department of Social Services has an attorney. So there are lots of advocates and lots of people that she's expected to talk to. And this has nothing to do with her immigration status, for example. So a different agency needs to come in and advocate for her to adjust her immigration status because she is in the system. And so although for this case, a lot of the things that I do is kind of assess fully. If this young woman had some kind of support system, and it was just, let's talk about basic baby supplies and how do we work with your parents to get it, to get you an ID. It's a very different response than what we had to do with this young woman. Again, because of all the things that were involved. One of the things also that I often see, particularly with young women that are coming to our ED, I often feel like we just want to make sure that they're well and we kind of just say, okay, everybody out. But I feel like there's lots of kids who may be at risk that we're not picking up. And that's not just here in Bayview, but also probably at the main hospital. I've seen lots of cases where a young woman or a young kid will come in saying, this is my uncle, but no one's really checking into who these people are. And oftentimes we have discharged those patients. And I'm very concerned, one of the trainings that I had in the last couple of years has been, victims are not always going to tell us that they're victim of abuse. And so lots of these kids that are here without support systems, without, with adopted uncles, I think we need to ask a little bit more questions as to who are these guardians that are walking into our EDs are. And that's why I really focus on that rapport building. And I know during COVID and, all of us are tired and, overworked, but I really think that spending a few minutes just kind of listening to people's stories tells us a lot about what's going on in their situations. And the more we understand and the more we listen, we're a little bit better capable to connect them to the resources that they need.
Thank you, Jess. There was a comment that actually builds on what you shared, or a question rather, from one of the participants about the patient's concern that the baby could be taken from her by CPS, particularly when paired with the team's concerns that because of her immigration status, she might not be able to provide for the baby. And I think that it's important to recognize, and Jess mentioned that DSS, I mean, it's a bureaucracy. The Department of Social Services is a bureaucracy. And Child Protective Services is meant to help, obviously, protect children and families, and is also a bureaucracy. And I've become very mindful that, at least in my experience as the Child Protection Team Coordinator, the rate of removal of children from non-English speaking families is higher than it is for families where the main language spoken is English, regardless of immigration status. It impacts a family's ability to engage in an investigation if they are not able to understand or respond to questions. And their fear of deportation or their fear of the child being removed, fear of removal is true across communities if they've had engagement with the public sector. But it's more so for someone who has previously been in detention due to government involvement. They may not understand, and this juvenile was in detention in a juvenile facility, and then placed through probably engagement from the Department of Social Services with family. Her ability to understand that the goal is to keep a child with their parent, her own experience may not reflect that. And again, I think, Child Protective Services does the best they can with resources that are not up to the task. They at times use police as their interpreter in investigations. And that, as one might imagine, does not necessarily foster sense of trust that law enforcement or immigration would not be involved. Is it a real issue that a child might be removed from their parent unnecessarily? Yes, not usually because of poverty, but because of lack of clarity about the family situation. And there's an additional question, I'm sorry. Who is the most competent person to make decisions for a juvenile in the absence of a parent? This is also complicated by the fact that this is a juvenile who has a child. And in Maryland, if you have given birth to a child, regardless of whether you are married, you are generally treated as an adult, at least in terms of being able to make medical decisions for yourself. Now, that's not the same as being able to make life decisions or being considered safe to be on your own in the community. But it does reflect why DSS may have been hesitant to take this as a case. This young woman was providing for herself, providing for the, well, she hadn't yet provided for the baby because she was still in labor and delivery, but she had been meeting her own economic needs, and now having given birth is considered an adult as far as the system goes. But as Jess mentioned, this is a 16-year-old who is still at tremendous risk, given her lack of resources, given previously having been abused. And so there are times where, with great advocacy, we are able to enlist the support of DSS to provide additional resources for juvenile patients. All of this comes about, and I'll be transparent. Our session today came about after a conversation within the ethics committee about documentation of immigration status for our patients. Zach mentioned in the introduction that word choice and a medical record can have profound implications for patients in terms of how they are perceived, and that perception on the part of a medical provider then impacting the way that they engage with a patient, perhaps unconsciously, but research has shown that it is definitively true. So even choosing a word such as patient refused care versus patient declined service provision can change the perception of that patient and their willingness to be engaged. What's true as well is that immigration status in the chart can then lead to perceptions of that patient's education status, that patient's ability to receive services. And quite honestly, depending on the person who documented, may not even be accurate in terms of whether they are an undocumented patient, whether they are a patient that has a visa, how they entered the country. And so what is generally recommended both by by various medical entities, the American Medical Association, the Academy of Pediatrics, and their associated ethics committees, is that immigration status very, very rarely should be included in any documentation because it's not medically relevant. What's more likely to be relevant is the ability to access resources, as has been discussed throughout this presentation, whether they're eligible for insurance and for other resources in the community. Zach, do you want to do a sort of summary or?
Sure, happy to. I want to thank all our panelists for their expertise and Senora Banos for being with us today as well. I think we've discussed experiences on the part of juveniles and children and adults, and I think a couple of points were shared in common in these cases. One is the fact that there's just not enough services or resources provided to these patients, despite the unstinting efforts of everyone in this panel and many other people at the institution. The second is that language concordant care is of vital importance to everybody throughout the process. And the third is that we need to understand the barriers that people face in getting care, especially people without documentation, that the system does not make it easy for these people, and we need to make things easier. And the final point that Simone mentioned that I'm going to emphasize is that one should take care to document those things in the chart that a patient needs and not what their status is. And that's, I think, a principle that we could all follow in our clinical care or support care of these patients. So I want to thank everyone, Mark Hughes and Ann Schuck, and for helping organize this talk, the panelists, and particularly Simone for activating us to discuss this topic. And thank you very much to everyone for your participation and attending. Have a good day.